Welcome back, everyone. It looks like we are having some folks continue to join this session, so we appreciate you all joining us for our second session today, which is another essential topic for rural healthcare leaders on provider compensation. Our second session today is integrating incentives in rural provider compensation, which will be led by two of our Stroudwater consultants, Opal Greenway and Shad Ritchie. And with that, I will go ahead and pass it to the two of them.
Thank you, Megan. So welcome, everyone. Happy that you guys could join us for our session today. We have a great topic talking about integrating incentives in rural provider compensation. We know that this is something that people have struggled with doing historically. A lot of people think that there's a lot of risks associated with putting any compensation at risk for providers. So I'm excited to present on this with my colleague Shad. Today, we're going to be going over some current market trends and what is going on with what does compensation look like overall in the market, talking about how do you pick out your incentives? Why do they even matter? Whether or not they're going to work, what are the importance? We will talk a little bit about the compliance requirements, especially when it comes to putting in incentive compensation. The regulations about that are a lot more stringent and paying attention to exactly how you format your different incentives. And then we'd like to present to you guys a case study where that we worked on with a hospital over a number of years, actually, that has successfully integrated incentives into their compensation structure. So we'll make sure we leave plenty of time for Q&A at the end. But with that, I'll go ahead and hand it over to my colleague, Shad.
All right. Well, thank you, Opal. I appreciate everybody being on today. And what we wanted to do is start with the current compensation market. In the area of rural health, we know that there's a lot of different current compensation models out there. And so what we wanted to do is start by talking about what forces are influencing compensation. And with that said, when you think about compensation in any market, especially rural, there's forces that cause compensation to go upwards. There's forces that cause it to go downwards. And then there's a few things that we'll talk about that are, kind of staying neutral right now. This just gives a background. So when we get into the incentive piece, it makes a little bit more sense. But with the regulatory changes, with Stark, anti-kickback, all of these things, COVID-19, for instance, value-based care, integrating that into compensation plans, what that is doing is it's causing supply and demand to be off a little bit. Everybody knows that right now that the supply of providers is low across the nation, and everybody is struggling to recruit providers to their organizations. So what that does is it's causing a dwindling of providers, and it's increasing demand because the patient volume is still there. It's just the supply of providers is lower. So what that does is it causes compensation to want to go up. Providers are expecting their compensation to go up if they have to be in a market that is in lower supply. The other component that we can say that has caused upward pressure is the pandemic. So the pandemic, COVID-19, everybody remembers that. A lot of providers, especially when I was in your roles in the operations component, a lot of providers they retired during this pandemic period, and because they were burned out, and that has caused the supply of these providers to dwindle as well. So what we have to do is come up with what are some good options for compensation to want to attract and retain providers in this market. Another component that you'll see on the upward pressures was the CMS fee schedule. And if everybody remembers, right around 2020, CMS or Medicare said that we are going to now value primary care providers differently than we did in the past. And that is for their evaluation and management codes. And so with that said, CMS said, we're going to increase the values for the work RVUs for primary care. That should have probably happened long before 2020 because all the work that primary care providers put into it with seeing patients and tracking all these quality metrics, that probably should have happened before then. But instead, this went into effect in 2020. The average increase of the work RVUs is about 26%. So the work RVUs went up. It didn't mean that the providers are going to see any more patients, but what this caused, the work RVUs by going up, it caused the compensation amount for the providers to increase. This was a chaos for a lot of organizations. Organizations didn't know what should we do with this data because this information came out. Should we implement the new fee schedule work RVUs? Should we not? So that caused a lot of concern in that area. So a lot of organizations did have to contemplate, do we implement, do we not? I will say a large majority did not implement the new fee schedule at that point in time. And Opal, feel free to chime in on any of that.
Yeah, one thing I would add, Chad, is one of the things that this really created is instead of it being incremental, normally we're seeing with a lot of specialties, they'll adjust their work RVUs a small amount each individual year. And then to have this 26% increase happen all at once during the middle of the pandemic, most organizations didn't have the administrative resources to get a handle as to what was going to be this on the impact of their compensation. And really, the only ones that this was truly impacting compensation is if they were based off of a productivity incentive, right? You saw no additional patients, you did not get any additional reimbursement, but productivities, the incentives were going up significantly with these increased work RVUs. So when it comes to incentive compensation, a lot of people are like, whoa, I need to back off of using incentive compensation. It's safer to have a base salary that I know exactly how much it's going to adjust each year from an administration standpoint. I know what my increases are going to be. I'm going to have control over that. And so we did see some organizations reevaluate whether or not it was appropriate to continue with incentive compensation in the productivity area when there was this unpredictability about what CMS was going to do with regards to the fee schedule and work RVUs that has historically been very reliable.
Yeah. Yeah, thank you. One of the last components for the upward pressure for providers expecting more compensation is over-reliance on surveys. And many of us who have worked in the industry for a long time, we know about MGMA survey, the AMGA, Stroudwater has a survey. There's multiple surveys out there, Sullivan Cotter, for instance. There's a lot of over-reliance on surveys. And so a lot of organizations will say, well, we don't really have a strategy, but let's start at the median compensation of XYZ survey. That may or may not be the best strategy for all these organizations that we're talking to today. So and a personal experience is that I would go into negotiations with providers and they would actually pull out of their lab coat a document that would actually show this is the latest MGMA data and I should be paid this for the work that I do. And that's not necessarily the case. They would also Google what they should be making online. And unfortunately, we have to educate our providers on what does fair market value mean and what does that, how does that relate to their compensation? And Opal will talk a little bit about that in a bit.
My favorite now is I have providers coming in and saying, here's what ChatGPT, I put in all my responsibilities. I put in how many patients I see. I show how many hours that I work each week. This is what ChatGPT says I should be paid. So that is the new, this year's the first time that I've had a provider pull that one out on me. So it is evolving.
It is. So those are the things that we're seeing that have pushed compensation upwards for organizations. Some things that have caused downward pressures are scarcity of resources. And Opal talked about this briefly, financial scarcity for organizations. I love when Opal talks about there's no printing presses in organizations. In the CEO's office, the CFO's office, you can't print any more money to pay providers if there's no money to be paid out. So there's the financial component that organizations have to consider. What is your net margin, and what can you afford to pay your providers if it's within fair market value? The other component is in rural organizations, the administrative scarcity. Many organizations have a small team of leaders, and you all wear different hats. And if you develop a complex compensation model, then you are really going to put more you're going to put more burden on your team, and that could cause some errors when you calculate your complex compensation models. So those were some things that caused some downward pressures of maybe we shouldn't increase compensation. Maybe we need to keep it flat or draw it down a little bit. The other piece is a lot of times individuals or organizations were concerned about fair market value. And how does the Stark law and the anti-kickback law, how does that impact compensation overall? And so a lot of organizations would say, well, we can't pay this because we're afraid of being penalized later. And like Opal said, she's going to talk a little bit about that later in the presentation. The final thing with neutral impacts, value-based care and Stark law changes. We thought that there was going to be some impact there, but that's to be determined, especially in the rural. You should still consider ACO dollars because people are just now, or organizations are just now getting into some of the value-based care components. You should still consider ACO dollars distribution and value-based enterprise Stark exceptions. So yes, but you have to be careful, and you have to support the analysis to be able to work those items in. So we're going to kick off a poll question really quickly, and we're going to see if our colleague Megan can ask this. And this incentive, so we're asking the question, which incentives do you use for providers? And we would like you to check all that apply. So there's good citizenship, shift premium, sign-on bonuses, retention bonus, maybe there's none. We'll give it a minute or a couple seconds. We appreciate everybody responding, by the way. So you might be on mute.
I see that some of you guys are showing it. Apparently it's only letting you click on one, that the multiple choice option or clicking on multiple is not working, but I will go ahead and say that if that's the case, if you're not able to click on multiple options, click on the one that you guys use most prevalently. And so as we're seeing, the majority of organizations are doing some sort of sign-on or retention bonus, not so much on the good citizenship or shift premiums, a little bit on that. And then about 20% of organizations are not doing any sort of incentive compensation for their providers.
Right. But it does look like individuals or organizations are thinking about incentive comp, which is really good, I think, for retention and recruitment. So with that said, we are going to move on to the next slide, where we're talking about industry trends and compensation methodology. And I don't know if that stopped sharing. Okay.
You're good.
Okay, thank you. So industry trends. So a lot of times in employed organizations, a lot of organizations, like we've already talked about, have a base salary, and then they have some sort of component related to whether it's production or quality or some sort of incentive component. And what's really interesting about these two graphs is that you'll see that over a period of time, and this data goes from 2018 to up to about 2023, 2024, you'll see that it varies quite differently year by year. But what has happened is in the past survey period, RVU based has dropped just slightly, but quality has dropped a little bit further. So I find that very interesting in that more and more people may be thinking about, well, do we include quality metrics in our incentives or not? A lot of times during the pandemic, there were, I want to say, gimmies. So providers, we could, in the pandemic, providers were having to see COVID patients. They were having to see all of these other complexities. They couldn't do their A1Cs, the make sure the mammograms, the colonoscopies. So what happened is a lot of organizations then went ahead and paid out quality bonuses without substantial data validation. The other component that what we're seeing is that on the pie chart is that a lot of organizations, when we are looking at their compensation models, a lot of organizations are incorporating the RVU or work RVU based incentives. And then they're also incorporating quality incentives. Something that we are seeing as a downtick is gross billing and net collections. A lot of times those are in independent organizations, independent private practices that may look at that versus employed organizations. So that is not as high. But one thing that we have seen is that patient encounters is something that you can track, especially in RHCs. And with RHCs, if you have an all-inclusive rate or you are grandfathered in an all-inclusive rate, that is something that we're seeing more and more with tracking patient encounters versus maybe just work RVUs. All right, with that said, we have another polling question.
So this question goes directly to what our next topic with regards to compensation will be call compensation. So that's something that we're definitely seeing an increase in. So we're asking people, are you paying for call? Are you paying for, and the answers that we have are you, yes, you are paying for call and you're paying for each individual shift of call that they are doing. Yes, we are paying for call, but only for call shifts above a minimum number that are required. No, we don't pay separately for call. We assume it's included in their base. Or no, we do not provide, or we do not require our providers to take call. And it'll be interesting to me how this question differs from what we have seen in the past. Because if I rewind when I started doing this work 15 years ago, almost all of you would have said, no, it is included in their base compensation. I am not paying separately for call. But that was 15 years ago and times have definitely changed. So it looks like we have a good number of people who have responded, and it looks like we're at about 32% are saying we are paying for call and that we are paying for each individual shift. 26% are paying for call, but only if it is above a certain number. And 35% of you are not paying for call separately at all. It is included in their base compensation.
Right. So with that said, when we're talking about call compensation, like Opal said, and like many of you answered, and historically, call compensation was really looked at as, okay, this is expected. You went into medicine to take care of patients, and so providers were asked to take call as well as see patients in clinic and surgery, those type things. Now what we're seeing in more and more organizations, especially rural, especially when you have a lower number of providers that are having to take calls. So maybe it's a 1 in 2 call, 1 in 3 call versus an urban area that is 1 in 7. The providers are coming to the administrators and saying, well, I have a lot of burden. I really need to be paid for call compensation. This doesn't mean that you can't pay for call, what we're talking about. It just means that it has to be appropriate. And when we talk about what is appropriate for call, you really need to think about the rotation frequency. What is the type of call? Is it telephonic, or do the providers actually have to come in to see the patient? What specialty are they in? And is the hospital, does it have a trauma level? So those are some of the components. So what we're saying is you can pay for call compensation, but you really want to make sure that you make the right decisions when you're paying for call, and also obviously get fair market value, whether it's independent groups or employed.
Yeah, one thing I would note on that, Chad, for those of you who use there are specific call compensation surveys out there, such as MGMA, Sullivan, Cotter, and Gallagher all have surveys that are specific to call. All three of those surveys do skew towards urban areas. And so people will look at that and say, well, here's the median call rate. You have to remember that those numbers reflect people who might have a 1 in 7 recall rotation, right? So their burden is overall it may be lower, but it may be restricted. They're presenting in person every single time. So while you have to make sure you be able to balance those pieces out, also thinking about, is the call rate different for your employed provider versus if you have an independent provider who is able to actually bill for the professional fees of any services that they provide. And since we're talking about incentive compensation, if you pay your provider a productivity incentive, do the work RVUs that they generate during a call shift go towards their productivity? So you have to be paying attention as to whether or not you might end up double dipping with regards to any of the compensation or what those payments are.
Great, thank you. The next item that a lot of organizations talk about is medical directorship and compensation for that. And a lot of organizations find it easy to be able to give people more money or give providers more money if they make them a medical director. And there was a gentleman on the call yesterday that indicated that he has more medical directors than he probably should have, but it helps with culture. So there's the good and the bad, but really what organizations really need to do is make sure that when you are assessing medical directorships, you have to rely on what is the rigor and the responsibilities of what this provider is going to be doing. Is it going to be something that is going to make a difference in the organization, not just something that is going to add compensation for doing little work? Also, if the person is less than a 0.5 FTE, it is really advisable that time logs are administered. We know that's not something that a lot of providers want to do. They don't want to track their time, but we want to make sure that everyone knows that, should you be audited, it would be a really best case to have some sort of log to be able to do that. One of the last components that I find really interesting is a lot of organizations will set a compensation and then they'll define the roles later. Really, that should happen the opposite way. You should define the role and then figure out what is the compensation that should be paid based on the roles and responsibilities. So we find a lot of times the difference. All right, I know I'm going to go to the last slide for me, Opal, if that's okay. So more than just compensation, when you're looking at compensation, you have to consider fair market value, obviously. And when you look at fair market value, a lot of times organizations will say, okay, this is the total compensation that we're paying dollar-wise. But you also have to think about what benefits are we offering? Is it cash or is it in-kind compensation? And for instance, think about, do we pay the full premium for dental insurance? Do we pay the full health insurance premium for them and their family? There's all of these things that need to be considered either by an organization or a consulting company can help with determining what is fair market value with determining compensation plus benefits.
And I think this is one of those things to really think about when you're thinking about how competitive your compensation is. And so therefore, should you put like what incentives or should you put anything sticky for any of these types of benefits? So one of the things that we've seen that always gives me a little bit of heartburn is when I see paid time off cash outs, right? Where they're allowed to cash out a certain amount of their PTO each year. I have seen organizations that actually didn't have limits on that at all. And so they would have providers who had productivity compensation. So they frankly were They were worried that their providers were disincentivized from taking any time off. So, in addition to having large productivity bonuses each year, then that provider would be nearing retirement or consider leaving the organization, and they would have this massive paid time off cash out, right? And I've seen organizations that had six-figure plus cash outs, which frankly, from a compensation standpoint, created a significant compliance issue for that organization. Not to mention if they're not making sure that they accrue it properly on their balance sheet and making sure that they can actually pay those out. So that is one of those incentives that being really thinking about how you are going to execute a paid time off cash out is really important to scrutinize and see how do I create the most stickiness, but also some limitations associated with using it, because you do want your providers to take their time off and make sure that they don't burn out. All right. So with that, thank you, Shed. I'm going to go into really thinking about incentives, getting into the meat and bones of this. When we think about compensation, like we all have jobs, right? And we're all getting paid to do those jobs. All compensation is what you pay people to do what you need them to do. You're paying them for their time, their knowledge, their skills, their abilities, and frankly, their commitment to your company. Like when we think about compensation, it is what I give you in exchange for the services that you provide and whatever that looks like. And that needs to look at in its totality. So when we think about compensation for an organization, we need to think about what is important to our organization, right? What is going to drive our organization forward? How much of it is tied to, do we need specific skill sets? Do we need a specific knowledge? Do we need them to be able to provide a certain level of services? How does our organization, how does our hospital make money? If we're very fee for service, then how is that reflected in our incentive state? So when we look at incentive compensation, as Shad was talking about the current, what's competitive, what's in the market right now, we notice rural is significantly in that bucket of we pay 100% guaranteed compensation. We don't have compensation at risk. We don't have incentive compensation. We have base salaries. So our survey last year was our second year of our survey. 54% of organizations said that they don't have any sort of incentive compensation. Shad, myself, and Megan were working on analysis actually yesterday, and it looks like that when we release our third annual survey later this summer, it looks like for the first time, rural will be at less than half of the organizations do not have any sort of incentive compensation, which when we look at the broader market, realistically, outside of rural, the larger national and urban market, only about 20% of organizations don't pay any sort of incentive compensation. So rural is very skewed towards guaranteeing that compensation. And part of that is they're worried that if they put any compensation at risk, that they're not going to be competitive. That realistically, they're not going to be able to get anyone to join their organization because, the different incentives won't be able to make sense. Now, a part of that is because they've seen that providers have done some pushback with regards to incentive compensation in recent years. Shad was talking about how there's questions about the data validity with regards to quality compensation. How applicable is it? So many of you guys have probably used patient satisfaction as a potential quality metric, which providers love because the survey goes out the same day as the bill, right? And so when they think about it, it's not something that they feel like they can control. And so how can we possibly have incentives that are tied to that, right? So when we think about it, what does compensation look like in rural? As I said, over half of us are over in this base salary and some sort of other guaranteed buckets, right? The call compensation, APP supervision, medical directorship, it's 100%. I know exactly how much I'm going to make this year. It's guaranteed amount. There's not incentive. However, when I think about, again, an organization's strategy and what drives an organization forward and where their compensation is, the better those two things are aligned, the more likely you are going to have providers be highly engaged in organizational strategy, organizational performance, and being able to achieve those goals. So if you think about it, it makes sense for providers to have specific incentives to drive the organization forward. So if you're a rural organization that is still highly fee for service, it makes sense to have some sort of productivity incentive in there. Now, the productivity incentive is something that should be set appropriate to what is in your market. If your market can't support MGMA median work RVUs because that's not what your patient population looks like, and it would be very difficult for a provider to ever achieve that. That's not really an incentive there, right? If it's something that they can't get, then they might as well just rely on their base salary, right? So it's important to think about what is appropriate for your specific organization and what you're trying to achieve. So maybe it's about productivity increases, right? Maybe you say that they need to cover 80% of their base. Um, before they get some sort of productivity incentive. Maybe it's 100% of their base, but it shouldn't necessarily just be, oh, okay, it's whatever MGMA median is before you get a bonus if that's not what's appropriate for your market. Now, if your organization is starting to get reimbursement associated with quality incentives, if you're part of an ACO, it makes sense to include those types of incentive compensations for your providers. Now, keep in mind when Chad was talking about quality incentives, and how people are thinking about the validity of that, and the fact that during the pandemic we had a lot of people look at quality incentives as give me's, right? Because there was pushback as saying, hey, I can't impact this, so just they got the payout of their quality incentive. Realistically, when it comes to quality incentives, technically these are supposed to be tied to quality improvement. You can't set a quality incentive where, hey, I'm going, as long as you maintain status quo, as long as you don't get worse, as long as your quality doesn't go down, you get a bonus, right? Those gimmes are really problematic because technically quality incentives, you're supposed to be focusing on quality improvement. Now in rural, I have to say it'll be quite a while, much further in my career before I think we'll see truly at-risk performance incentives that are tied. Typically, we see those in the Kaisers, the Geisingers, some of those large organizations that especially have their own health network. We don't see those in rural, and I don't think we're going to see them anytime really soon. Even organizations that might be part of like Caravan Health or some of the large ACOs, we haven't really seen them put providers at risk for anything associated with the cost of healthcare, unless, of course, they're an independent provider, because then obviously how much they take home, the incentive compensation is very much tied to them being able to control the cost of providing that care. So again, why does this overall matter? And part of the big thing is because we simply can't afford for our compensation to be divorced from our organizational strategy, right? If we know that like so many of the organizations that we work with at Stroudwater have have their strategy saying we're going to expand primary care, but they don't have their primary care providers incentivized in any way, shape, or form that actually drives them to grow primary care. And so the question is, okay, well, then how do you achieve that strategy? Is it them being able to improve patient access and expand primary care based on the number of visits? Or is it just recruiting more providers? And if it's just recruiting more providers, that's a very expensive endeavor. And so we want organizations to reconsider, how do we make money and can we actually incentivize providers with that while still maintaining our compliance? If you go on to the next slide, Chad, I mean, we can see what's happening. Hospitals are closing because of the fact that they're not financially sustainable. And if your biggest item on your P&L is the cost of providers, besides once you already have that fixed facility, right? The next biggest line item and expense for you on an annual basis is really that provider spend. So if you're not managing it, you end up being one of these dots on this map, right? Because you have to be paying attention to the overall financial sustainability. So when we look at incentives, there's some significant benefits to actually incorporating it. First of all, you don't have to have just one kind of incentive. While we said we don't want you to make it overly complex and the administrative burden and the risk of getting things inaccurately if you have it, it doesn't have to be one size fits all, right? We prefer incentive compensation that fits with the provider type. Your surgical specialist should have one kind of incentive compensation versus those that are clinic-based versus hospital-based. You need to see what's appropriate for what am I having this provider actually do. And one of the things that we've seen that works really well is when you actually engage with the providers as to what matters for them. What do they think about the organizational strategy? What can they do to drive the organization forward? Are those things that it would be appropriate to tie some sort of incentive to? Now, when we look at productivity, it also forces us, when we think about a productivity incentive, to be like, okay, am I asking my providers to work at their highest and best use, right? What is the work I'm asking them to perform? Is it something that actually drives the organization forward, or am I asking them to spend a lot of time on things that aren't really all that productive, right? So I don't want them wasting time chasing things that are never going to create an ROI for the organization. And so it gives us the rigor to actually really focus on our data, make sure that there's a business case for any initiatives that we're doing on our organizational strategy. And so, because if we're going to pay out some sort of incentive for it, then I better make sure that it's something that's going to create an ROI. And for those of you who attend any of Eric Shell's talks about, what makes a really successful organization, that data-driven culture, you want everybody in the organization, but especially the providers, to be asking for the data. If you were to just at Amy and Wade's last presentation with Paula with regards to data, you know how much that data and it being accurate and having providers engage with it on a very frequent basis on this regular cadence becomes part of the culture as to whether or not your organization moves forward. Now, also providers, I don't know about you, but I've never met a provider that wasn't just at least a little bit competitive. And so having that healthy competition within a group can be really helpful for driving an organization forward. And the last thing that we see that incentive compensation really does is it has us pay attention to pay equity. I was at an organization in Louisiana not too long ago. I've been working with them for years, and they had a very highly productive provider who'd been there for 17 plus years. She was fantastic. She was a medical director. She drove the organization forward and was committed. And then she found out that she was constantly seeing 24 patients per day in primary care. She'd round on patients in the morning, also at the hospital. And she finds out that they've recruited somebody from an urban area who's come to Louisiana, tired of the pandemic and the big city life, and that provider's making 70,000 more than her for seeing only 10 patients per day. Yes, he was in a ramp up period, but that seems completely unfair when a provider looks at here are the services I'm providing and have historically provided. How is it possible that I am making the same amount as another provider who is doing significantly less just because they are newer? So incentive compensation can really help us make sure that we're grounded in that pay equity and we're looking at it on a very frequent basis. Now, obviously, if this was super easy to do, everybody would have already done it, right? There are challenges. One of the things that we've seen is people decide to overcomplicate this significantly. They're unclear because what they'll do is instead of having a compensation plan, they'll set this provider. They recruited this provider and they decide to do it for this provider. Well, they got some pushback, so then the next provider that they recruit, they tweak it some and they're not the same. And next thing you know, administration is trying to execute 20 different compensation plans, right? All with similar incentives, but all just different enough that it makes it really complicated and nobody knows whether or not it's actually being accurate, if it's fair, what is the basis for it. Same with these unreachable incentives. Like I said, if you tell a provider, hey, you get a bonus only when you hit 6,000 work RVUs and they're primary care and they've never hit more than 4,200 work RVUs, then what's the point, right? An incentive that carrots that they cannot be reached, they forget that the carrot even exists. It doesn't even matter anymore. And I have to say that is something that we see incredibly frequently, especially in rural, because people aren't using rural specific data or analyzing their market as to what is achievable in that market and what does it make sense for actually covering the cost of that provider or where the provider has been historically, right? If you realistically look at where a provider's been historically and incentives require them to have more than a 10% improvement for them to ever hit it, then they stop engaging with it. That to us has always been the magic number. If they have to do more than 10% better, then it's not really an incentive anymore. Another challenge, obviously, is it does require being able to get reliable data. You have to make sure, now keep in mind that reliable data is also really important to make sure that you're able to bill and get the money in correctly, right? I'm sure for those of you who listen to Amy, right, this is an absolute key thing. So if you know that the money's coming in the door, then hopefully you have the good data to actually engage with providers with regards to what is their performance, how many patients are they seeing, what's their productivity numbers, what's their quality data. If you don't have the data analytics, you cannot pay providers for. You will get huge pushback. You'll have provider turnout. Now, one of the things that we continue to hear as far as a challenge is providers are pushing back on some incentives. Now, most of the time it's because, hey, is it something that they actually have control over? Is it why they're actually providing care? So understanding, can you show them the information about, hey, do I have high producing providers that have really good quality to show, hey, let's look, work our views don't have to be a distraction. You can see a significant number of patients, or you can have the high acuity of patients, give them good care, and it doesn't actually compromise that. It's okay to have this kind of incentive. So you need to be able to look at your information and look at your providers and make sure that this is that is actually something that they can do, right? And so that you have a good message for when a provider says, well, the only realistic way to be able to have good quality is to only, spend an entire hour with the patients and only see 8 patients per day. Now, one of the things you have to do is with incentive compensation is to constantly be reevaluating it, right? Is it actually changing the behavior in a way that is effective for your organization? If you put incentive compensation into place and you realize the organization's not moving forward, it forces you to reevaluate. Did we pick our incentives correctly? Is this really what we were supposed to be doing? Is this driving the organization forward? If it's not, be prepared to change it. And I know that, changing compensation is something that can create a lot of upheaval. They say the 3 hardest things for a CEO to do is an EHR conversion, of a new build of a facility, and changing provider compensation. And so it's not something you want to do all that frequently, but you have to evaluate whether or not the incentives you put into place are actually working. So with that being said, thinking about the types of incentives that people do, I like, when a provider's coming in, you start out with some sort of annual guarantee. They want to come in, you want to have that sign-on bonus, you want to have something that says, makes them feel secure in the community, but you should set the expectation as to how is this base actually set? What are the expectations? How did you come up with it? Is it presuppose that they are going to see 16 patients per day, 10 patients per day, 20 like what are they building up to? Because if you're not upfront with that as to what is included in their base, then the incentives won't even matter, right? Like whatever you put in. So then if you can talk to a provider about, all right, here's what I consider a 1.0 provider. Here's what is included in their base, which means it also sets the expectation that if they're not hitting that after a few years, base compensation may need to be adjusted. It might be going up because they're exceeding that significantly, or it may need to go down because they're not hitting those numbers. When it comes to productivity incentives, as Shad was talking about, the most common we see is tied to work RVUs, but we have seen compensation per visit. And one of the things that I've seen for rural organizations that has worked really well is thinking about panel size compensation, and especially panel size growth for a new provider. How is that panel growing? If you do your compensation based off of panel size, you will want to think about acuity adjusting those panels. So if you have a panel of somebody who sees primarily healthy patients, the 18 to 35 or 40-year-olds versus somebody who specializes in geriatric medicine, then you want to make sure that that panel size is right sized for the acuity of the patients that they see. Very few, like the value-based compensation, quality incentives are considered value-based compensation. Again, you really want to focus on driving that towards what things that they can actually impact, but also what is your organization measured on? So those are usually the metrics I look at first. And is it appropriate for that specialty? Obviously, cardiology is not going to have the same metrics as a primary care provider or a hospitalist or an ED provider. One of the things that I've really liked is actually doing something with value-based compensation where you actually take the productivity incentive and you adjust it up or down based on whether or not they've hit those quality metrics. So while many of you might be used to quality metrics of like, hey, here's 5 metrics, each one's worth $2,500, so you can get an additional $10,000. For organizations that are trying to balance productivity and quality and make sure that they have really high quality, or they're really trying to improve their quality, you may have set, here's your productivity conversion rate of compensation per work RVU, say it's $50. If you have high quality, that conversion factor goes up. If you have poor quality, maybe it stays the same or potentially even goes down, so that we're making sure that providers are not compromising quality in exchange for productivity. And then with regards to medical directorships, I actually like putting specific incentives in there for the medical directorships of saying, here, if you have these responsibilities, but you do a great job of it and the organization does well, you get a bonus for as a medical director, right? Same with APP supervision, is another one of those that I actually like having specific metrics in there where they could actually get additional compensation rather than you might have a baseline of, say, medical directorship's 150 bucks an hour, but then they get an additional 5% at the end of the year if they hit their department hit specific metrics, right? Reduced transfer rates for ED and hospitalists, or primary care good quality scores, or some sort of improvement on staff turnover, right? Different things like that. So we would be remiss if we didn't talk a little bit about the compliance piece of it, just because we are seeing so much more of this in rural than I ever thought we were. I'm starting to see critical access hospitals get penalized for not being within fair market value and not following these rules. There's a reason for it. It's because it's our biggest line item, right? When we think about our cost on our P&L as a hospital or a health system, provider remuneration is the most significant expense. So of course, it's very heavily regulated and it keeps on changing on us, but those base rules have been pretty much the same with regards to how they've been applied, what we've looked at. So the specific laws and statutes that apply are the Stark and anti-kickback statute. Now, one of them is the criminal penalty, which is the anti-kickback statute. One of them is Stark. You hear a lot of focus on Stark because it's a strict liability statute. What does that mean? It means we don't care. The government doesn't care whether or not you meant to break the rules. If you did not dot your I's or cross your T's, you are in violation of the statute, right? So it doesn't matter, whether or not you meant to, it matters that you did. And so versus the anti-kickback statute, there has to be something you intended to. It really was tied to some sort of kickback, some sort of rewarding patient referral, et cetera, right? There was something nefarious going on. The issue with these two laws as to why do we pay so much attention to them is because the penalties, if you are found in violation of one of these laws, what happens is it means you're in penalty of the False Claims Act. And under the False Claims Act, what it does is that any penalty associated with that provider, for the full life of that provider's contract. So say you've had a provider for 10 years, every single Medicare claim, and in some states the Medicaid claims as well, that provider has signed off on is the size of the penalty times 3. So you have a provider who builds $1 million in Medicare each year. You've had them for 5 years. There's $5 million times 3. There's $15 million in penalties. Plus there's additional, like actually per instance penalties as well. But you see how that can get really, really adds up. So the fact that they're going after critical access hospitals, independent hospitals, rural now, we need to pay attention to it. And you need to educate your providers on this because the providers are liable as well. It's not just the hospital. I just read about a case last year where the individual physicians each had to pay $750,000 each out of their own pocket for the violations. Yes, the hospital in that case got the big ticket penalty of 36.5 million, but providers don't want to write a $750,000 check either. This is big business for the government, and especially when we think about the fraud and abuse claims that are going on now and that scrutiny over it. It was $2.9 billion to the US government last year for pursuing this. They get $4.30 for every dollar that they invest in enforcing these. They get $4. It's a 4.3 times return on investment for the government. So they're not going to just look the other way. So that being said, we have another poll question just to make sure, see, hey, does everybody got dotting their I's and crossing their T's? So if you think about your current compliance policy, right, and this one, it does look like you should be able to click on multiple. What are you currently doing? So are you getting fair market values done regularly by a third party for your new agreements? Do you have it part of a compensation plan? Is your board reviewing compensation? Do you engage providers using a provider compensation committee? You're doing coding audits? And are you documenting compensation plan? And since it's anonymous, if the answer is none, don't be scared of actually putting that as well, of saying, hey, nope, we don't do anything for compliance. We won't out you, I promise. All right. Okay, well, so it's looking like a lot of you, 38%, you guys do regularly have a fair market value analysis as part of your compensation plan. 40% of you are doing regular coding audits. 30% of you actually do have, make sure you have a documented plan. 20% of you have nothing in place right now for a compliance piece. So thinking about that going forward as a takeaway, evaluate what you have going on there. So, all right. So I mentioned fair market value, and there was a question in the chat actually of talking about fair market value specifically with regards to rural healthcare, right? Where it doesn't feel fair because it's really hard to recruit, et cetera. Now, when it comes to compensation, what is fair market value? It's not survey says, it's not MGMA median. You have to look at it in totality. What is the provider's specialty? How long did what's their training and experience? How long did it take you to recruit? If it's really hard to recruit a provider in, you've had this position open for 3 years, you can pay more for that if you document it. You can't, right? You need to show when did you initially start trying to recruit for this? Is there a community need? Do I have a lot of wait times? Can I not get a patient in for 4 months to go see a provider? Is it a new specialty? Do you have seasonality, right? Are you an island provider who, where people only come during certain times. We do a lot of work in Colorado, and people come during ski season and mountain biking season, which means March is dead, right? And so when we think about that, that's something to take into consideration because you can't only have providers for a certain time of year, you need them year round. Is there a specific community benefit? Is there a huge call burden, right? Do we not have jobs for other like for spouses? Do we have to get two providers because it's a dual provider household? So thinking about those things are really important to take into consideration for fair market value. It's one of those things that a proper fair market value analysis will take all of that into consideration, right? And so as long as it is well documented, you may be within fair market value, even if you're paying at the 60th, 70th percentile, but the provider might be at median level services, right? As measured by work RVUs. Now, being a reformed lawyer, I have to say, on behalf of those lawyers who are actually doing the enforcement on this, the reason why so many people pay attention to the MGMA data is you have to keep in mind the people who are doing enforcement of this, they do not have a healthcare background. They have never worked in a hospital. They're not a provider. They're not a clinician. They've never done the billing, etc. So they use survey data to say, okay, as just a test, it makes sense to pay median level compensation for median level services. Well, how do we measure that? Well, since CMS is who issues work reviews, that should be fair. So 50th percentile compensation for 50th percentile work reviews. That makes sense to us. Okay, there might be some market specific factors where maybe you pay 50th and they're only performing at the 40th. But then again, us lawyers and the ones that don't have a healthcare background might be like, wait, why would you pay the 70th percentile if they're only performing at the 40th? That doesn't seem right to me. Again, they don't have the background and maybe they don't work in rural. So that means maybe I should look into this. Maybe I should see whether or not in compliance. And so this is why it's so important to document all of these things and to understand what is being put into the compensation so that you can show them, hey, no, there's a reason for why I'm paying the 70th for 40th percentile. Because you cannot expect the people who are doing this enforcement to just know why is this fair for your community. And one of the big things that actually should be taken into consideration is the compensation methodology. If the provider has any of their compensation at risk, that is a significant factor that is paid attention to when you consider fair market value. So when everything is guaranteed, that, regardless of the level of services, that can raise a red flag. So that's part of why we talk about this, is what the importance of actually looking at incentive compensation. So with that, I want to go over into our case study, that we talk about. So this is a Midwest hospital that we worked with, right? It's a 25-bed critical access hospital in there in the Midwest. It's pretty isolated. There's another hospital that is a PPS hospital, but it's over 45 minutes away. So the CEO is somebody I had worked with years prior. He's a brand new CEO in this organization, brand new. He had previously been a practice administrator, VP of physician affairs, and and looking at outpatient services. And he walks in and he says, nobody's paid the same. It's all different. It's all over the place. I don't know what is the logic behind anybody's compensation? It looks like it's just whatever they negotiated with whoever was CEO at that time. On top of that, the hospital was losing money. And for the very first time in the hospital's history, the board had actually approved a negative operating budget. So they're very highly concerned about their financial success, but they don't want to piss off any of the providers. And they don't have a set strategy for here's how we set compensation. On top of that, they had the CEO joins and they have providers coming up to the CEO saying, okay, I haven't had a raise in years. How am I supposed to make more money? Right. And then we asked them specifically, when we started this engagement, we asked them, you know, where your fair market value is to justify like the compensation that you do have in place. Now, yeah, we definitely have that. They thought they had a compliance piece. And when they sent it over to us, it was a printout of the AMGA survey. And they said, well, somebody said as long as we stay below the 90th percentile, we're fine. So they had several providers who were being paid at whatever was 90th percentile the year that that provider joined. And that they thought that was what was fair market value. And again, this is one of those things for those providers. They didn't know better. This was not intentional. This was not nefarious. This wasn't trying to be outwit the PPS hospital by paying more and trying to steal their providers. This was literally, I mean, I was presenting in Alabama and a CEO came up to me. She's like, my lawyer wants to know, I texted him during lunch and wants to know when that STAR clause was passed. Early 2000, like it's been 25 years, because their legal team also gets them, gets you out of a DUI on Saturday, right? And also does your real estate deal. They're not necessarily healthcare specific to know these laws. So I love this quote because it's perfect for so many of our rural organizations. The two buttons they never, if you watch Ted Lasso or in the past, I love it. The two buttons I never like to hit: panic and snooze. So here it was, a provider felt, or the CEO felt, oh my goodness, I have providers who I'm paying a ton of money to. We're losing money. I don't want to lose any providers, but I don't know how to set compensation, and I'm really worried about potential compliance risk, right? But don't panic, but I can't wait to look at this, right? Even though he's brand new, brand new CEO, let's go in and blow up compensation, right? So what he engaged us to do, he's like, I want a compensation plan. Like, we'll deal with the compliance issue. Let's work with legal on that. But I want a compensation plan. I want a model that I can utilize that is, hey, it aligns with the organization's strategy. It's competitive. I'll still be able to recruit. I want to reward my high performers because there was a lot of variation with regards to how people were performing. You had the primary care provider seeing 18 patients and you had the one seeing 9, right? He wanted to be able to be really transparent with his providers and think about it in holistically as to what were all the providers getting. I wanted to see, hey, under the new plan, will I be within compliance? And I want it to be transparent. The providers need to know how to make more if that's what they want to do, or if they need flexibility for, I want to be part-time, I want 3 10s, right, in the clinic, or I want to change how I address my shifts. And then there was a little side piece of like paying attention to, he's like, I think I want to employ CRNAs going forward. So what did we do to execute this engagement? We did our process. We always do. We start out with data, we review it, we try to figure out what's going on. We work with leadership to kick off the engagement. In this case, and I will say with all of our compensation engagements, we actually put together a provider compensation committee because it's really important for the providers to be engaged. If you do incentives that the providers have no say in, it's not going to work. I've never seen one of these work. I won't do it, right? We interviewed all of the providers, find out what's important to them. And then we came up with a straw man and developed a model. And we went back and forth with the providers about this model to see what was going to work. And we used that compensation committee to basically evaluate each of these, and then we actually were able to put together an implementation plan. So what was interesting is when we interviewed the providers to see how they felt about their compensation, so many things came back about the benefits package, right? And so it showed me that the providers really needed some education with regards to benefits because they felt like the health insurance was too pricey, that they should, that shouldn't be considered part of their compensation. The providers like, what do I care about tuition repayment? Because I've been here forever, I don't have student loans. What can you give me if I don't need the student loans? They wanted to know whether or not they were really competitive. There was a independent clinic across the street. Are the primary care providers making, a comparable amount? And then when it came to productivity incentives, the providers were very open to this, and some of them were used to seeing this, but they said only if you address our coding, make sure we're educated on it, make sure I get the feedback on it. You guys are doing everything you can from a revenue cycle and making sure that my data is really valid and that I'm getting engaged with it on a very regular basis. The cadence of seeing the data was absolutely important to them. So we made sure, actually, we said we're not going to go live on this for a year so that we can make sure that the data, you really truly believe the data. So what did we end up putting together? So for this organization, we had primary care, we had behavioral health, and then we had shift-based medicine, ED hospitalists, and the wound care people actually went back and forth between clinic and we're also working as ED and hospitalist providers, right? Everybody who worked in wound care kind of worked in other places as well. So I outlined kind of the goals that they had for the organization. They wanted to make sure it was competitive, that they could grow, it was going to be sustainable, that it was going to be efficient. But one of the things in the interviews that came out was staff turnover was a big deal to them, right? So making sure that you rewarded loyalty, retention, tenure, making sure people with rural experience and knew what it was like to work in rural and weren't going to leave after their 2-year guarantee was a really important goal for that organization of how do we put this into the compensation. So what they had historically, everybody had a base and benefits and they got add-ons. Some people had housing, some people had sign-on, some people had retention, some people got relocation. It was very inconsistent, but nothing was at risk, right? There was no incentives. So what we did is we put together where primary care and behavioral health, because they were both clinic based, they ended up with a base salary, productivity incentive, and quality. And what we did was we actually adjusted base salary. Here was a starting point, and based off of your tenure in the organization, your rural experience, good citizenship scores, your base salary would start out either higher or lower based off of those things that were important to the organization. And we would have adjustments that were very transparent with that. And then for anybody who is shift based, we had them, we didn't give them productivity incentives. It was an incentive for taking extra shifts and not having to be able to use locums. So overall, it was a great engagement. It took 3 years for them to absolutely be able to execute it. It's working well. Since they gave providers an option of move on to the comp plan immediately or stay on your current comp plan for up to a year to make sure that they had time to get adjusted to what the changes were. Right? They were able to have that guarantee that was blessed. We had a legal make sure it worked with from a compliance standpoint. We had to redraft everybody's contracts, but we got them all on the same schedule, which made it really a lot easier for administration to actually execute these because they knew exactly when contracts were up for renewal. And then we met with each individual provider to show them a side-by-side comparison of like, okay, if you do nothing different about how you perform, here's how much you will make. If you see this many more patients, here's what it'll make. If you do this many shifts, here's how much you will make. So the providers felt very transparent with it. So far it's working great. Every time I talk to this hospital, they're very happy with it, and so have been the providers. So with that, I did want to leave a little bit of time for Q&A. I know we've answered some of them as we've been going along. So let's go ahead and go to that. Shad, I'll let you take this. Oh, go ahead, Megan.
Nope, go ahead, Opal. I was just going to say we are at time, but I think we do can have a few minutes for a question or two if you would like to.
So, Shad, I'll go and do this one for you because what incentive would you not pay for? Is there one that you don't want to pay for?
Well, you've already addressed this earlier, but patient satisfaction is really difficult. I've had so many providers in my career come to me and they say, well, you should pay me more money because I have high patient satisfaction per Press Ganey. And I say, thank you so much for that patient satisfaction. That's expected. But what I would say is that it's hard to, if you have a comprehensive Press Ganey survey, you may want to funnel that down to one question. If you're going to pay for patient satisfaction, pay for one question. And that question could be, how likely am I to refer that somebody in my family or friends to that provider? And that is a strong correlation to how much people prefer that provider. So I think drilling it down to that one level is really better than having the overall Press Ganey patient satisfaction survey.
Awesome. Well, thank you, Shad. I know we're at time. We do get the questions, so I'm trying to answer some of them in the chat while Shad was talking. And for any ones that we didn't get to, we will send it out with the recording. So thank you everyone for joining us today.
Yep. Thank you, everyone. And thank you, Shad and Opal, for your great presentation. We really hope we will see everyone again tomorrow. Tomorrow we will be shifting our focus to survey readiness, strategic partnerships, and facility transformation. We'll see you all tomorrow. Thank you.